Hi, I'm Rochelle Andriotti from Vanderbilt University, and I'm going to be speaking about 3D sonography of the uterus and adnexa problem solving. In the next 30 minutes, I'd like to have some fun with a series of patient cases demonstrating problem-solving techniques using 3D sonography of the uterus and adnexa. I have no relevant financial relations to disclose. So as an artist has carved a work of art from a dead tree in this park in Bordeaux, France, we will slice through 3D volumes to obtain our work of art, which is a final product that answers a clinical question. So problem solving surrounds the use of the reconstructed coronal plane. The coronal plane of the uterus and adnexa usually can't be visualized using traditional 3D imaging, but it answers important questions that could not be previously addressed with traditional 2D imaging. And the majority of these applications will involve the uterus. And as you can see here, we have a surface-rendered 3D coronal image of the uterus, which of course is normal. So I'd like to show examples that illustrate practical applications of 3D sonography of the pelvis. This will include assessing uterine shape anomalies, improving visualization of the entire IUD, delineating and locating abnormalities associated with the endometrium, and reconstructing the fallopian tube when adjacent cystic structures are demonstrated. So first, what are the manipulations that we need to use in order to reconstruct the image? First, there's a manual or automated sweep, which is performed to obtain a volume through the acquisition plane, which is usually the sagittal plane of the uterus. Then a multiplanar format or display will appear on the screen, which are 3 orthogonal planes with or without a surface-rendered image. And this surface-rendered image is a thicker slice through the volume with depth perception that is improved by different computer-generated shading and lighting effects. And then, of course, we'll slice or rotate using a marker dot or line to select the scan plane from the volume. So here we have an example of the multiplanar display. First, you can see that we have the acquisition plane, the sagittal plane, and we have these lines, the blue line representing the coronal plane, the green line, the transverse plane. So first, our first quadrant is the transverse view of this sagittal acquisition plane. And our third quadrant would be the coronal view sliced through the midline of the endometrium. And then we have our surface rendered image in the fourth quadrant. So here is an enlarged view of the surface rendered image where we've rotated it so the fundus is on top, the way we usually like to view the coronal view of the uterus. So let's go through how we might actually perform this manipulation. So here we go. So let's line up the endometrium with the horizontal line, the Z-plane, which is our coronal plane. So right here, we'll be lining it up. And we'll have to rotate the uterus a bit so that we are in perfect alignment. Then we also want to line up the endometrium in the transverse plane as well. And then we'll come over to the coronal plane where we can first rotate it so that the fundus is on the top and we can view it in a plane that we're more used to seeing. And then we can enlarge it and we can manipulate the image by rotating in both the X and Y planes so that we can see this entire IUD on one image, which we will see in just a second here. Voila. So first, let's look at some uterine shape anomalies. So why is it important that we determine what type of uterine shape anomaly the patient has? First, uterine anomalies are associated with an increased risk of infertility and obstetrical complications. The correct diagnosis helps to minimize complications and manage infertility. So the need for intervention and the type of intervention is determined by the proper classification of the anomaly. So one of the most useful applications in anomaly evaluation is to determine the etiology for two cavities seen by 2D imaging. So each of these images represents a different anomaly, and there are different managements for each. So before we look at each particular anomaly, I'd like to just show you the classification of uterine malformations according to the American Fertility Society. And as you can see, the coronal plane best delineates these anomalies. What we're going to be talking about mainly are the most common anomalies, which are on the spectrum of the arcuate and septate uterus, as you can see here, and the bicornuate didelphys uterus, these two images here. So let's first look at this patient, a 24-year-old gravida 4, para 4, with recurrent pregnancy loss at 11 to 15 weeks gestational age. So we can see our first patient with two cavities. We do our reconstructed coronal plane, and we have what we call the sub-septate uterus, where we have a partial septum and a smooth fundus. So the septate uterus is an AFS Class V. It's the result of lack of resorption of the uterine septum after complete fusion of the Müllerian ducts. It may be partial or complete. As I mentioned, there's always a smooth fundal contour, or occasionally it might be slightly undulated, but very, very small. It's associated with early pregnancy loss, and the management of infertility includes a procedure, a hysteroscopic metroplasty, removal of the septum. So here's a second patient, two cavities. This is a 27-year-old gravida 1, para 1, with a history of a spontaneous vaginal delivery at 34 weeks gestational age. We do our reconstructed coronal plane, and we have two separate uterine horns, the uterus didelphys. So this is a complete duplication anomaly, an AFS Class III, where we have lack of Müllerian duct fusion forming two separate uterine horns, two endometrial cavities, and two cervices. And it also may be accompanied by two hemivaginas separated by a longitudinal or transverse septum. This is associated with miscarriage and premature delivery, as was the case in this patient. And it is not amenable to surgical management, as the septate uterus would be. So here we have our third example of two cavities, a 25-year-old gravida 0 with the incidental finding on a pelvic ultrasound performed for abnormal bleeding. So this is the arcuate uterus, an AFS Class VI, which is the mildest form of a septate uterus, where we have a minimal septum, as we can see here, which is somewhere between 5 and 10 millimeters, indenting the uterine fundus. And I say 5 to 10 millimeters because if it's under 5 millimeters, it's not really even considered an anomaly. This is commonly considered a normal variant. No intervention is necessary, although there are some reports of increased second trimester loss in preterm labor. So here we have another patient, a 32-year-old gravida 2, para 2, with a history of premature delivery at 28 and 32 weeks. And as we can see, very widely placed uterine horns. So is this a uterus didelphys, or is it a bicornuate configuration? And I'm showing you this sweep through the uterus in the transverse plane just to show you how difficult it is by 2D imaging in this transverse plane to really determine which it is. Are there really two separate horns here, or is this a bicornuate uterus? We really can't tell, although we do know that there is some separation of horns. So this is a bicornuate uterus. As we can see, there are two uterine horns, but they do join immediately above the cervix. So a bicornuate uterus is a class 4, which is the result of incomplete fusion of Mullerian ducts. It consists of 2 uterine horns with 2 endometrial cavities that join above the internal os of the cervix, like I already mentioned. No intervention is necessary, but this pregnancy would be managed as high risk. And we would also know that a complication such as a vaginal septum that we would see with a uterus didelphys would not be anticipated. So just as a review, we can see the difference between the spectrum of the septate uterus and the fusion anomaly, where we see pretty much smooth contour, although we do in this case have a little bit of an undulation with a septum, as opposed to 2 separate uterine horns in the fusion anomaly. So next we have a 29-year-old gravida 1 para 1 with a history of premature delivery at 29 weeks. Now, is this a uterine anomaly? Actually, this is kind of a trick question because I don't think you would actually think that I would be showing you a normal uterus when I'm talking about fetal anomalies. But actually, when we do our reconstruction in the coronal plane, this is a unicornuate uterus. And this is the only type of uterine shape anomaly where we would have absolutely no suspicion of an anomaly on 2D imaging. But on our 3D reconstruction, this would be the only method to actually make this diagnosis. So the unicornuate uterus, class 2 AFS, is a result of failure of development or incomplete development of one of 2 Mullerian tubercles. We have the presence of only 1 uterine horn, or there is a difference in size of 1 horn when compared to the other, and usually it's a significant difference. And this is associated with miscarriage and premature delivery. So much for uterine shape anomalies. Let's move on to some cases demonstrating IUD malposition. First, we have a 26-year-old gravida 1 para 1 presenting to pain clinic. And as we can see here, there is at least a portion of IUD within the endometrial cavity on this 2D sagittal view. When we do our reconstruction, we can see our multiplanar display here, and we can see on this thin slice coronal view that the arms do appear to be very low within the endometrial cavity, embedded in the myometrium. And on our surface rendered view, we can see even better where the shaft of the uterus is and can see very nicely that this IUD is actually upside down with the arms embedded in the myometrium. Another patient, a 29-year-old gravida 1 para 0, presenting with pelvic pain. Once again, we see that there is some IUD within the endometrial cavity, but we do our 3D reconstruction in the coronal plane, and we actually can see that there is some sort of peculiar position of this IUD. When we rotate the uterus and enlarge the surface rendered view, we can actually see that what we were seeing in the main cavity was actually the arms of the IUD, and the shaft projects into the cornual region and is somewhat embedded within the myometrium. So, IUD visualization. We can see here that 2D transvaginal sonography can confirm the position of at least part of the IUD in the uterus, as we saw on these patients. But when abnormally located, 2D may show that part of the IUD is embedded in the myometrium, but usually cannot demonstrate the entire IUD on a single image. But the 3D coronal view has been used successfully to improve visualization of the entire IUD and arms, all on the same image. So why is this important? Well, embedded IUDs are a major cause of pain and bleeding in patients. And Beryl Benacerraf and her group looked at 167 patients with malpositioned IUDs and found that 75% of these patients presented with pain or abnormal bleeding. So now let's move on to some examples of intracavitary abnormalities within the uterus. First, we have a 44-year-old female, status post-rollerball endometrial ablation and bilateral tubal ligation, who's presenting with dysmenorrhea. And we can see here on the sagittal and transverse images that we have a fluid collection that seems to be associated with the endometrial cavity. Here's another patient, a 34-year-old female, status post-thermal endometrial ablation, presenting with right lower quadrant pain, hasn't had a menstrual period for about a year. And this patient also has fluid collections. On the sagittal view, we can see one of them, and actually on the transverse view, we see that there are two fluid collections associated with the endometrial cavity. So where are these fluid collections, and why are they there? So here we can see both patients with the uterus in the coronal plane. First patient has this fluid collection over here on the left, and then the second patient has the two fluid collections, one on either side, and also has these little structures here and here that appear to be in the interstitial portion of the fallopian tube. So what is this diagnosis? Before we actually talk about the diagnosis, let's take a look at each of these patients separately. First, we have a Cornual hydrosalpinx within the left uterine cornu in the first patient. And in the second patient, we have two Cornual hydrosalpinges. And these little structures here are what we call Adiana devices. They're contraceptive devices like Escher coils that many of you may be familiar with that are placed within the interstitial portion of the fallopian tubes to cause granulation tissue to set in for tubal occlusion and contraception. So the diagnosis here is a problem that has been described as post-ablation tubal sterilization syndrome. First, we have an endometrial ablation in these patients, ablates the endometrium within the main cavity. Then we have tubal obstruction because of the bilateral tubal ligation and the Adiana devices, contraceptive occlusion of the fallopian tubes. And these patients may still have functioning endometrium within the uterine cornu. And because of that, retrograde menstruation into the remaining proximal tubal segment can cause severe unilateral or bilateral pain. And this syndrome was first described by Townsend, actually, back in 1993. So next patient is a 37-year-old gravida 2 para 2 presenting with dysmenorrhea and lengthening menses. And let's look at a cine clip through the endometrium of this patient. And really, it's very difficult just looking at these 2D images to determine if there's anything associated with this endometrial cavity that's causing this patient's problem. But when we do our reconstruction in the coronal plane, we may have a reason for the abnormal bleeding. We have this echogenic structure within the left endometrial cavity that is actually an endometrial polyp. And there is absolutely no way we would have been able to pick out this polyp on our original 2D imaging. Here's another 55-year-old gravida 2 para 2 with postmenopausal bleeding. We have a thickened kind of globular endometrial echo here, and the endometrial biopsy showed benign pathology. So what's going on? We can see here on our color Doppler image that we do have color Doppler flow, looks like a feeding vessel maybe, associated with the endometrium, which would be highly suspicious for an endometrial polyp. But in our 3D image, we can see the shape, origin, and extent of involvement of this polyp, which gives us even more information than just being suspicious that there is a polyp. And a hysteroscopic polypectomy was performed in this patient. So a little bit about endometrial polyps. They're rarely malignant but associated with abnormal bleeding and cramping. They're seen as echogenic masses within the endometrial cavity, best demonstrated with a contrasting proliferative endometrium. Frequently, the location and number are identified more accurately on the coronal view, as we did in this patient. And usually, they cannot be diagnosed by a curettage. These structures cannot be scraped off or aspirated. So curettage with insufficient tissue, when we see a thickened endometrium by ultrasound, usually means there is a polyp. And the final diagnosis in these patients is made by polypectomy, which is performed by hysteroscopy. So now let's move on to another type of intracavitary abnormality, a 31-year-old gravida 0 presenting with a history of infertility and menorrhagia. And as we can see here, we have fibroids associated with the endometrial cavity on this sagittal and transverse view of the uterus. So the relationship of fibroids to the endometrial cavity is often better evaluated using sonohysterography, which is installation of saline within the endometrial cavity. So here we have the 2D sonohystogram in this patient, and we can see that the larger fibroid has at least a partially submucosal component associated with the endometrial cavity. And the smaller fibroid actually looks like it's completely within the cavity, just using 2D sonohysterography. But with 3D sonohysterography, thin slice, and with surface rendering, we actually see that both of these fibroids are pretty much completely within the endometrial cavity, which was really not seen nearly as well on the 2D sonohysterogram when it comes to the larger fibroid. And hysteroscopically, we can see this fibroid within the endometrial cavity. So let's move on now to a 30-year-old gravida 3, para 3003, with history of menorrhagia and multiple pregnancy losses. We can see on our sagittal and transverse views that this is a fibroid uterus, has some more peripheral fibroids that are intramural, subserosal, but the one we're most concerned with is this one right here that appears to be somewhat associated with the endometrium. And on our 2D sonohysterogram, we can see that the fibroid has at least a small submucosal component along the left uterine cornu. But when we do our 3D sonohysterogram, we can actually see that most of this fibroid actually projects within the endometrial cavity. So let's just take a look at what the advantages of 3D sonohysterography may be over 2D sonohysterography. First, fast imaging acquisition of data would decrease the length of the time the patient is undergoing discomfort and potentially decreases the time it takes to perform the study. And using the acquired volume can retrospectively help us to reconstruct images in any plane. And then the 3D shows a more accurate location and better delineation of intracavitary abnormalities, actually with or even without saline, although the saline may give additional information due to enhanced contrast, which was actually shown in a couple of reports by Levtov and then Kowalczyk. So let's just talk a few minutes about the management of submucosal fibroids and what the role of 3D reconstructions would be. The options for management depend on the patient's symptoms, fibroid location, and desire for future pregnancy. And in a patient with fertility, who desires fertility preservation and there's a submucosal location, the fibroid is best treated by myomectomy. And 3D can help us determine the type of myomectomy that's needed to be performed. First, a hysteroscopic myomectomy could be used for those fibroids that are submucosal with at least 1 centimeter of intracavitary extension. And then a myometry by laparotomy or laparoscopy would be used, of course, for those that are intramural or subserosal, but also for those with a very minimal submucosal component, which could actually be visualized with 3D sonography. So just for the last few minutes, let's take a look at how 3D might help us in the adnexa. Here we have a postmenopausal female presenting for follow-up of asymptomatic left adnexal cysts. So of course we see this cystic structure within the adnexa on the left. And usually we're going to knee-jerk and we're going to say these adjacent adnexal cystic structures, we're going to assume that they're ovarian or adnexal cysts. But by placing the horizontal line, the Z line that represents the coronal plane through these cystic areas, we may be able to find a plane that elongates into a tubular structure. So here we go. Here is our horizontal line going through this cystic structure. And what we see here in the coronal plane is a tubular structure is actually formed. And then we also see it on our 3D surface rendered image. Here's our surface rendered image once again, and here we have what's called an inversion mode as well. So the inverse mode produces an echogenic cast of the cystic area that can be extremely helpful in confirming the configuration of the tube. And using the inverse mode or the surface rendered mode or even just the thin slice reconstruction may save the patient a surgical intervention, since a complex cystic mass in the adnexa would usually require surgery, whereas a hydrosalpinx would not. So one more example, a 42-year-old gravida 1 para 1 presenting with left lower quadrant pain for follow-up of left adnexal cysts. And once again, we see a complex cystic mass in the left adnexa. We do our sweep sagittally through the adnexa, which then gives us the multiplanar display. But we really don't find a tubular structure when we try to perform a reconstruction in the coronal plane. However, going back through the volume in other planes, and in this case, actually in the initial sagittal view, we actually can come across a structure that looks like this. Tubular, looks like a fimbriated end, and here we have the inverse mode showing, once again, a tubular configuration. This looks like a fallopian tube. So what we learn from this is that we should not limit ourselves to slicing only through the coronal plane if we are suspicious for a fallopian tube. We have the whole volume. We can slice through the other planes as well to try to get the structure that we are suspicious may be there. So some key points from 3D imaging of the uterus and adnexa. This will provide some clinically useful information, especially if abnormalities associated with the endometrium are suspected. It's the modality of choice in uterine shape anomaly assessment, and there is really no need for MRI. 3D can be used with or without saline sonohysterography to better delineate and locate abnormalities associated with the endometrium. It improves visualization of the entire IUD. And finally, it can be used to reconstruct the fallopian tube when adjacent or septated cystic structures are demonstrated. So, thank you.